I would like to introduce our last speaker of this session, Dr. Rick Schreiber, who is going to speak to us today about the new home-based screening program for biliary atresia, which is using the infant stool color card, which he has just started to pass out amongst you in the room, and improving the health of British Columbia newborns. This is a new screening program that Perinatal Services BC is taking on with Dr. Schreiber. I'm happy to help lead the program, and I'd like to welcome you to the presentation. Thank you.
Thank you very much for the introduction, and thanks for staying for this session. I notice it's snowing outside. I'm thinking of Sochi, and here I'm on the podium, the last person to go down that run, and we had gold medal speakers before me, so whoa. But what I'd like to do with you is to share with you some of the information about the new home-based infant stool card screening program that we're currently launching here in British Columbia. And what my objectives are today is to give you an overview of what is biliary atresia, what's this rare pediatric liver disease, sort of a 101 on the liver disease itself. I'm then going to go through with you some information about our Canadian experience. How are kids in Canada faring with this rare liver disease? What's their outcomes looking like? And then I'm going to go over a recent CHR study that we did here at BC Women's to look at the feasibility of starting an infant color card program in Canada, how families and parents would respond to that kind of program, and what kind of data we got. And at the end, I'm then going to go over for you the details of the implementation of our new BC-wide Perinatal Services run infant stool card screening program for biliary atresia. We've already launched it in August, and we're currently rolling it out across the province. So biliary atresia, it's a very rare disease. It's 1 in 19,000 births. That's pretty rare. Cystic fibrosis, for example, is 1 in 2,500. It is the most common cause of pediatric liver disease. It's the most common reason for why kids get cirrhosis, and it's the most frequent reason why kids die from liver-related liver disease. It is the leading indication for why kids go for liver transplant. It accounts for over 60% of all transplants in children. So this is a uniquely pediatric disease. One doesn't see biliary atresia in adults or in older children. It's a disease that only happens in the newborn period. And what's going on there is that in all patients, there is this progressive obstruction or block of the bile duct. That's the tube that drains fluid from the liver to the intestine. And one of the fluids that's being drained is bilirubin. And this obstruction happens only in the perinatal period. It's not in utero, it's not genetic. It happens soon around or after birth and progresses in the first months of life. And condition becomes clinically evident at around 2 weeks of age when kids develop progressive jaundice, which is due to a conjugated hyperbilirubemia, in association with these very pale chalk white stools. And that happens because the bilirubin is no longer getting into the intestine. Bilirubin makes your stools pigmented. There is treatment for this problem. It's called the Kasai Operation. That was named after a Japanese surgeon who developed the operation in 1959. And what they do in that operation is they basically take away this obstructed bile duct and they bring up a loop of bowel to act as a new pipe or a new conduit so that the bile can flow again and the bilirubin can clear. So a successful operation is when the baby loses the jaundice after the operation and the stools then again become colored. And this operation then will prolong the chance for the kid to live with their own liver without needing a liver transplant. On the other hand, if the Kasai operation doesn't work and you don't relieve the obstruction, the liver continues to fail, there's progression of disease, and these kids then need a liver transplant or else they're going to die, and that happens by the age of 2. So it's a very rapidly progressing condition that starts early and needs to be treated, or else your child is dead by 2 years of age. That's pretty amazing. So what's the most important factor that improves the outcome for children with biliary atresia? Well, that's the age at which the child goes for that Kasai operation. And we know that the best outcome is done if the kid has the operation before 1 month of age. Here I'm showing you some statistics. This is called the Kaplan-Meier Curve, and it shows the difference of outcomes for kids less than 30 days to over 90 days. And this is their chances to live with their own liver. So if you have your Kasai less than 30 days of age, you have a good 50% chance of living really into late adolescence with your own liver. On the other hand, if the Kasai only happens after 3 months of life, you only have a 10% chance of living with your own liver. Otherwise, you need a liver transplant or you will die. Now, in Canada, we know that 8% of kids, only 8%, get their Kasai at 1 month. And in turn, over 20% of kids are having their Kasai late, after 3 months of age, at a time when we know the outcome is bad. Well, it's nice to see all these statistics, but I'm a pediatric liver doctor. And here's what's happening in the field. This is a kid who is now 6 months of age. He had biliary atresia. He was diagnosed and he's had his operation at 41 days of age. He's 6 months, he looks great. He's no longer jaundiced, he's thriving, he's happy. He's gonna do well, he's gonna live with his liver. Now look at this kid. This kid came in at 93 days of age. Okay, he had a Kasai operation, but it didn't work. He's now 6 months of age. This kid looks like those adults you know who have cirrhosis. He has a big belly loaded with fluid. He's got venous distension. He's risking for gastrointestinal bleeding. He's very jaundiced, and he's really thin. He's not growing well. He's emaciated. This kid's going to die unless he gets a liver transplant. And doing a liver transplant for these small kids is not an easy feat. So there's a big difference here. So what's the problem? This is a worldwide problem. There's late referral for biliary atresia, the late diagnosis. Why is that? Well, first of all, it's a very rare condition. In Canada, we're seeing it in 1 in 19,000 births. It's a little more common in the Asian population, so in BC, it's about 1 in 10,000 births. But you know, few doctors, nurses, or healthcare providers are ever going to see one of these cases in their entire career. It's just not on their radar screen. The second thing is like finding a yellow needle in a yellow haystack. You guys know jaundice is very common. 2/3 of newborns are going to be jaundiced, but rarely, only 1 in 10,000 of those newborns are going to have this disease. So in the vast majority of cases who have jaundice, they're going to have benign jaundice. Even those who have prolonged jaundice, they're going to have breast milk jaundice. It's very unlikely to have that yellow needle in that huge yellow haystack. It's just not appreciated that they're there. And also, there's a lack of appreciation about the importance of stool color. Parents don't know to look at baby's poop color. They're surprised when their baby poop color is green. They think that's very abnormal, but that's not a concern. What's a concern here is this pale color. So if you have a jaundiced infant whose stools are now pale, that's a very high indicator that that bile duct is blocked and you're dealing with a liver problem. But healthcare providers, nurses, parents, they don't know to look at poop color and what's important to look for actually seeing pigment, not seeing pale stools. And the last problem is that in Canada, routine visits by healthcare providers for newborns are at 2 weeks, and then they see them at 8 weeks of age for their first vaccine. And there's a window that's being missed when this condition needs to be picked up. Because if you pick it up by 2 months of age until you get it going, it's a late referral. So we're missing the window of opportunity for early diagnosis and timely treatment intervention. So there's a lack of awareness, late referral, there's delayed management that has a poor prognosis, lower rate of native liver survival, a greater need for liver transplant like that kid I showed you, and clearly this is more cost, not just in terms of cost to the families, but healthcare dollar costs. So in Japan, Dr. Matsui developed this infant stool color card. And in Taiwan, they introduced that as a national screening program for this rare liver disease, biliary atresia, in 2004. And basically, the instructions here, which are Chinese to me, are in different colors. Their parents are instructed to look at the poop colors of their kid. The doctors are given these cards, and they're told if they notice the kid poop color is abnormally pale, to go see their doctor and then get an assessment. Since they introduced this program, they have not seen a single case of a kid referred late for biliary atresia, and they've increased the liver survival rate from 37 to 65%, a huge change just from a simple poop card. So in Canada now, I told you that only 8% of kids are referred early. We have this problem that 20% of kids are coming in after 3 months of age. We need to do something to shift the distribution. And the idea is earlier detection, more timely referral, better age of Kasai, better outcome, longer risk for living with your own liver, less need for liver transplant, and lower health care costs. So with all that in mind, a group of us at BC Children's Hospital, funded by CHR, had a study looking at the feasibility of introducing this poop card to Canada. How would Canadian families respond to this? How well would it work? Would it be cost effective? Well, we did phase 1 part of this study at BC Women's Children. Our aim was to evaluate what's the best way of introducing this screening program and what's the most cost-effective way of doing it. So here we created a poop card. We had these cards issued to families at the time they were discharged from maternity. We had the ward nurses instruct the parents to monitor the kid's poop color for every day for the first month of the baby's life. And then the parents were asked to complete, this was a business reply card, to complete this card at 1 month with what their kid's poop color was, etc., so we can assess how parents were using the card. We actually then created a series of interventional strategies. So step 1 was really just distribution at maternity. And then we said, well, will we get better cooperation if we sent out a reminder letter to the families at 3 weeks? Would we get even better cooperation and outcome if we then not only sent a reminder letter, but also did a phone call to the family? Would we get greater outcome if we had the physician involved with this and get them to mail back a card or give them a phone reminder to check their infant's, the baby's poop color in their office? We then returned back to the same as step 1 just to see if we had what we call a temporal effect on the outcome. We did phone surveys to assess card utilization, and we did a whole cost-effective analysis out of all this. Well, we had, during the time period, we had 6,800 births at BC Women, and look at that, 6,100 families enrolled. 90% enrollment rate. That's pretty unusual for a study. The parents were ecstatic. They signed consent. They were really engaged. The nurses were engaged. This is easy. I'm happy to do this. I want to go home and follow my kid's poop color. And in the end, we had 90% utilization of the infant stool color card. That's an incredible number. It's very simple, and it was very highly cost effective. And to be honest, the cost of printing one of these cards is a penny. So it's really cheap. So we found out that the best thing to do is actually just give the card out at maternity. The doctors didn't do so well. Only 13% of them participated. Nothing new. And also, we found out that by the time the kids got to the doctor's office, it was too late. They only, 2 to 3 months was the time we were getting back the cards. Not an efficient time to do the study. So the best way to do this is right out of maternity, give the card to the families, let the parents do the screening. It's the best, most cost-effective strategy. And also, I want to remind you, this is a very new screening strategy in Canada, or actually in the world. It's family-centered. It's home-based. You're asking the parents to be engaged with screening. This doesn't involve healthcare professionals or nurses or public health. Not that they're not good, but getting the families engaged in the care of their own kids, that's new. In addition, there's no test. You don't have to send back a blood test. You know, we do screening tests for colon cancer. You send back stool. There's no stool sample. There's no test to send back. All you have to do is monitor the color, and then if there's a problem, make a phone call. So it's a very simple, home-based screening program. So why couldn't we do it in the current screening program? Well, biliary atresia is as rare as other diseases like phenylketonuria or other diseases that we're currently screening in the newborn screening program. The problem is that their lab test, the heel prick test that we do, you cannot detect biliary atresia through that test. There's no single convenient laboratory test for the early diagnosis of biliary atresia. So we couldn't incorporate anything into the current newborn screening program. That's why we had to develop the CARD program. So the CARD has proven efficacy, earlier referral, timely intervention with improved outcome. That's what we're looking for. So with all that in mind, we launched the Stool Color Card program in the summer of 2013. This was through the auspices of Perinatal Services BC. We had taken our CHR data, we did knowledge translation, we presented it to many different places, BC Women's Children's Hospital, Child Health BC, Public Health Nursing, Perinatal Services BC, right across, and they quickly realized this is a very simple, cost-effective program. We launched it in 2013. We already rolled it out in Vancouver Health and Fraser. We are currently in the midst of doing the island, and we are then going to move into the interior and the north. So we hope to have it completely launched certainly by the summer. What we're doing here is all maternity ward nurses are involved. They're giving in-servicing. They're provided with a script of information, which I'll show you in a minute about the screening process and what information they need to relay to families in order to have successful screening at home. We also send out letters to healthcare providers and to all the midwives in the province. The letter has information about the program, and they all get a card, so they know what's going on in case a family calls them with a problem. They know what to do. We've also involved public health nurses to remind families when they do the home visits, or if families aren't calling them, that they know about the program and they can add added education to the program. And finally, we have a website up for parents' information about biliary atresia and the screening program. So here's the stool card. You can see it here. I kind of handed it out to everybody. These pictures are of abnormal and normal stool colors. We're asking parents to check their baby stool color every day for the first month after birth. If the parents notice an abnormal stool color that's depicted in number 1, 2, or 3, they're asked to contact Perinatal Services BC. They can do that through a 1-800 number, they can do that through email, or they can even fax us, and we pick up the information. We also have this new, I don't know if you guys are smartphone savvy, but there's a QR code here. You can actually scan it, and you will receive, the parents can sign up to receive a text message on their cell phone or on email that reminds them every week to check their baby's poop color, and we keep that going every week until a month after the baby's birth. So there's all these things to keep reminding families to do what we'd like them to do in the screening program. This is a sample of the maternity ward nurse script. You can see it's very simple. It has 6 points about showing the parents the poop card, about telling them the importance of following the stool color every day, and who to contact if they notice something abnormal. The parents in maternity can actually scan the QR code before discharge to start getting their text messages. And then the nurse is asked to just assign the BC newborn clinical infant form that they've actually done the teaching, much like you tick off that you did the heel prep test for the newborn prior to discharge. This is the www Perinatal Services BC website. Effectively, you go there and you just click on screening programs and you select out biliary atresia. It'll have a lot of information about the disease that I just explained to you and about the screening program. We also have the infant card available in many different languages. We're not asking families to print out the card because depending on your printer, the colors could be different. So we want them to actually use the card that they're given. But if they don't understand the language on the card, they can certainly look up and get their language-friendly card version. And finally, for the individual maternity wards, there's an easy online reorder system so that they make sure they have enough cards on the ward for distribution so we don't run out of supply. We don't want to be in a situation, well, for 2 months parents didn't get the card. That's not good. Actually, we need every single kid in the province screened. There are 44,000 births in the province. If you're looking for a disease that's 1 in 20,000, you need to make sure you screen everybody in order to pick up the 3 to 5 cases we're expecting to see every year. So you can make a difference not seeing kids like this. We want kids to be like this. It's a rare disease, but it's important that we detect it early to optimize outcome. I just want to thank the Perinatal Services BC. They've been an incredible team headed up by Kim Williams. Our program manager, Julie McFarland's right here. Janet Walker is our lead quality and education person. We have someone helping, Taslin helping us with knowledge translation. Lisa is our administrative assistant, and Lubna is doing all our communications with the communities around BC. So I want to thank you very much for your attention, and I'm very happy to answer questions.
I'm from Quebec, and I think we participate at some point in the research to see how it will work with mothers. Does the program will be extended to other provinces? Where are you at with this?
Well, oui, bonjour, je suis de Montréal, né à Montréal. Welcome. Yes. I didn't realize we were having people from across the country. It's a great question. I'm glad you brought that up. So we ran phase 1 of our study, the CHR study I explained to you about, in BC to determine what was the best strategy. We then went to check it out to see, does it work in other places? So we ran it in Prince George in the north, a rural community, not a fancy tertiary care hospital, and we ran it in Quebec at St. Mary's Hospital in Montreal, which is a multicultural hospital center that has a large French population, but they also have population from the north, from Nunavut. So we actually had a lot of different cultural people in it. It turns out in Quebec the study actually ran better than in BC. And why is that? They already have a newborn screening for neuroblastoma where they have to send back urine at 3 weeks. All parents have to send back a sample of their baby's urine at 3 weeks. So we changed our program a little bit, requesting card returns at 3 weeks, not 4 weeks, and we had a huge, fantastic response from the population. So it was very successful in Quebec, more than anywhere else. And yes, our next place to go to try to get it launched would be in Quebec. It's our next task. Thanks for the question.
The neonatologist, Dr. Kovacs, that was working, was asking recently about it, so I can give him the update.
Absolutely. If you'd like to be involved, we'd love to have you involved in our team.
Thank you.
Thanks. I'll take your name down after. All right. Well, thank you very much for your attention.
Thank you, Dr. Schreiber.